Hello everyone and welcome back to a Vital Nursing 101 video. Today we are going to talk about corticosteroids, specifically prednisone and methylprednisolone. These medications are very common in nursing practice. You may see them ordered for asthma exacerbations, COPD exacerbations, allergic reactions, autoimmune diseases, arthritis flares, inflammatory bowel disease, skin conditions, certain cancers, transplant-related conditions, and many other inflammatory or immune-related problems. But corticosteroids are also very testable in nursing school because they affect so many body systems. They can reduce inflammation quickly, but they can also increase blood sugar, increase infection risk, cause mood changes, increase blood pressure, cause fluid retention, irritate the stomach, thin the skin, weaken bones over time, and suppress the adrenal glands. So today, we are going to break this down step by step. We will talk about what corticosteroids are, why prednisone and methylprednisolone are used, how they work, important side effects, major warnings, nursing responsibilities, lab monitoring, patient teaching, and what findings should be reported to the provider. And throughout the video, I will add pop test questions to help you think like a nurse. Let's start with the basics. Corticosteroids are medications that mimic hormones naturally made by the adrenal glands. The adrenal glands sit on top of the kidneys. One important hormone made by the adrenal glands is cortisol. Cortisol helps the body respond to stress, regulate inflammation, support blood pressure, affect blood sugar, and influence immune function. Prednisone and methylprednisolone are glucocorticoids. That means they have strong effects on inflammation and the immune system. A simple memory tip is, steroids suppress swelling and the immune system. That is helpful because corticosteroids are often used when the body is too inflamed or the immune system is too active. For example, during an asthma exacerbation, the airways are inflamed and swollen. A corticosteroid can help calm that inflammation. During an autoimmune flare, the immune system may attack the body's own tissues. A corticosteroid can help suppress that immune activity. But here's the key nursing point. The same medication that calms inflammation can also weaken the body's ability to fight infection. That is why nurses must monitor carefully. Pop test question. Prednisone and methylprednisolone are best described as what type of medication? A. Corticosteroids. B. Antibiotics. C. Anticoagulants. D. Opioids. The correct answer is A. Prednisone and methylprednisolone are corticosteroids with anti-inflammatory and immunosuppressive effects. Now let's talk about prednisone. Prednisone is an oral corticosteroid. It is commonly taken by mouth as a tablet or liquid. Prednisone is actually a prodrug. That means the body converts it into the active form, prednisolone, mainly in the liver. You do not need to overthink that for beginner pharmacology, but it helps explain why liver function can matter in some patients. Prednisone may be ordered for many conditions. Examples include asthma flares, COPD flares, rheumatoid arthritis, lupus, allergic reactions, inflammatory bowel disease, dermatitis, and other inflammatory conditions. You may see prednisone ordered as a short burst. For example, prednisone 40 mg by mouth daily for 5 days for a COPD exacerbation. You may also see prednisone ordered as a longer taper. A taper means the dose gradually decreases over time. For example, the patient may take a higher dose for a few days, then a lower dose, then lower again until the medication is stopped. Why taper? Because if corticosteroids are taken long enough, the adrenal glands may slow down their own cortisol production. Stopping suddenly can cause adrenal insufficiency. We will talk more about that later. Memory tip. Prednisone by mouth. Inflammation goes down. Pop test question. Prednisone is most commonly given by which route? A. Oral. B. Inhaled only. C. Rectal only. D. Intraosseous only. The correct answer is A. Prednisone is commonly given by mouth as an oral corticosteroid. Now let's talk about methylprednisolone. Methylprednisolone is another corticosteroid. It can be given orally, but nursing students often see methylprednisolone in injectable form. You may hear the brand name Solumedrol for methylprednisolone sodium succinate, which is commonly given IV. You may also hear Medrol for oral methylprednisolone tablets, such as a Medrol dose pack. Methylprednisolone may be used for allergic reactions, asthma exacerbations, COPD exacerbations, multiple sclerosis flares, lupus, inflammatory bowel disease, arthritis, and many other inflammatory or immune-related conditions. In the hospital, IV methylprednisolone may be ordered when faster systemic effect is needed or when the patient cannot take oral medication. For example, a patient with a severe asthma exacerbation may receive IV methylprednisolone to reduce airway inflammation. A patient with an acute multiple sclerosis flare may receive high-dose IV methylprednisolone. A patient with severe allergic inflammation may receive methylprednisolone as part of treatment. Memory tip: methylprednisolone may be IV when inflammation is intense. Pop test question: which medication is commonly seen as IV Medrol in the hospital? A. Methylprednisolone. B. Acetaminophen. C. Loratadine. D. Ibuprofen. The correct answer is A. Medrol is a common brand name associated with IV methylprednisolone. Now let's talk about how corticosteroids work. Corticosteroids work by decreasing inflammation and suppressing immune activity. They reduce the production of inflammatory chemicals. They decrease movement of certain white blood cells into inflamed tissues. They reduce capillary permeability, which means less fluid leaks into tissues. They also suppress the immune response. That sounds complex, so let's make it simple. When the body is inflamed, it is like an alarm system that is too loud. Corticosteroids help turn down the alarm. A memory tip is: steroids turn down the immune system's volume. This is helpful when the immune response is causing harm, like in asthma swelling, autoimmune inflammation, or severe allergic reactions. But it can be risky because the immune system also protects the body from infection. So corticosteroids can mask infection symptoms. Mask means hide. A patient on corticosteroids may have an infection, but not show a strong fever or inflammatory response. This is why nurses cannot rely only on temperature. We also assess heart rate, blood pressure, respiratory status, mental status, wounds, urine symptoms, cough, sputum, and overall appearance. Pop test question: corticosteroids reduce inflammation partly by doing what? A. Suppressing immune and inflammatory responses. B. Killing bacteria directly. C. Increasing platelet clumping. D. Replacing insulin. The correct answer is A. Corticosteroids reduce inflammation by suppressing immune and inflammatory activity. Now let's talk about why patients receive corticosteroids. A common reason is respiratory inflammation. In asthma and COPD exacerbations, inflammation and swelling can narrow the airways. Corticosteroids help reduce airway inflammation. They do not act like rescue bronchodilators, such as albuterol. Albuterol opens the airways quickly by relaxing smooth muscle. Steroids reduce inflammation over time. So if a patient is wheezing and short of breath, they may receive albuterol for quick bronchodilation and a corticosteroid to reduce inflammation. Another reason is allergic reactions. Corticosteroids may be used to reduce delayed or prolonged inflammation in allergic reactions. However, in anaphylaxis, epinephrine is the priority medication. Steroids are not the first life-saving medication in anaphylaxis. Another reason is autoimmune disease. In autoimmune conditions like lupus, rheumatoid arthritis, or inflammatory bowel disease, corticosteroids may be used during flares to reduce inflammation and immune activity. Another reason is neurologic inflammation. High-dose methylprednisolone may be used in some multiple sclerosis flares. Another reason is replacement therapy in adrenal insufficiency, although prednisone and methylprednisolone may not be the only options. The key nursing question is always, why is this patient receiving the steroid? Because monitoring depends on the reason. Pop test question: a patient with an asthma exacerbation receives albuterol and methylprednisolone. Which statement is correct? A. Albuterol helps open the airways quickly, while methylprednisolone reduces inflammation. B. Methylprednisolone is an antibiotic. C. Albuterol causes immune suppression. D. Steroids replace oxygen therapy. The correct answer is A. Albuterol is a bronchodilator, and methylprednisolone is a corticosteroid that reduces inflammation. Now let's talk about common side effects. Corticosteroids affect many body systems. Common side effects include increased appetite, weight gain, fluid retention, increased blood pressure, elevated blood glucose, mood changes, trouble sleeping, stomach irritation, acne, and facial puffiness. Some patients may say, "I feel wired, I cannot sleep," or "I feel more emotional." Steroids can cause restlessness, irritability, anxiety, mood swings, or even more serious psychiatric effects like mania, depression, confusion, or hallucinations in some patients. Corticosteroids can also increase blood sugar. This can happen even in patients who do not have diabetes, but it is especially important in patients with diabetes. A patient with diabetes may need closer glucose checks and medication adjustments while on steroids. Memory tip: steroids raise sugar, pressure, appetite, and mood. Sugar, hyperglycemia; pressure, blood pressure and fluid retention; appetite, hunger and weight gain; mood, insomnia, irritability, mood changes. Pop test question: which blood value commonly increases with systemic corticosteroids? A. Blood glucose. B. Oxygen carrying capacity forever. C. Platelet lifespan. D. Eye color. The correct answer is A. Systemic corticosteroids can increase blood glucose levels. Now let's talk more about hyperglycemia. Hyperglycemia means high blood sugar. Corticosteroids increase blood sugar because they promote glucose production in the liver and make the body less sensitive to insulin. This is very important in nursing practice. A patient with diabetes may have well-controlled glucose at home, but after starting IV methylprednisolone, their blood sugar may rise significantly. You may see higher glucose readings in the afternoon or evening, depending on the steroid schedule. The provider may order blood glucose monitoring and insulin coverage. Nurses should monitor for symptoms of hyperglycemia. These include increased thirst, frequent urination, fatigue, blurry vision, and sometimes confusion. In severe cases, especially in high-risk patients, very high blood sugar can contribute to dehydration or hyperosmolar hyperglycemic state. As a nurse, do not ignore high glucose just because the patient is only on steroids. Steroids are a common reason glucose rises in the hospital. Pop test question: a patient with diabetes starts IV methylprednisolone. What should the nurse monitor closely? A. Blood glucose. B. Hair length. C. Shoe size. D. Eye color. The correct answer is A. Corticosteroids can increase blood glucose, especially in patients with diabetes. Now let's talk about infection risk. Corticosteroids suppress the immune system. This can make patients more vulnerable to infection. It can also worsen existing infections. It can also mask signs of infection. For example, a patient on prednisone may have a serious infection but not develop the same fever response that you would expect. So nurses need to assess carefully. Look for cough, shortness of breath, sore throat, painful urination, cloudy urine, wound drainage, redness, swelling, confusion, weakness, and general decline. In older adults, infection may show up as confusion, weakness, or decreased appetite rather than fever. Patients on long-term or high-dose steroids may also be at risk for opportunistic infections. Opportunistic infections happen when the immune system is weakened. Another important teaching point is avoiding exposure to contagious illnesses. Patients taking corticosteroids should tell their provider if they are exposed to chickenpox, measles, or other serious infections, especially if they are not immune. Live vaccines may not be appropriate for some patients on high-dose immunosuppressive steroids. Patients should talk with their provider before receiving vaccines. Pop test question: why can infection be harder to recognize in a patient taking corticosteroids? A. Steroids can mask signs of infection. B. Steroids turn infections into allergies. C. Steroids cure all infections. D. Steroids make fevers impossible in every patient. The correct answer is A. Corticosteroids can suppress immune responses and may mask typical signs of infection. Now let's talk about GI irritation and bleeding risk. Corticosteroids can irritate the stomach. Patients may experience nausea, indigestion, heartburn, or stomach discomfort. the risk of GI bleeding may increase, especially when corticosteroids are combined with NSAIDs like ibuprofen, naproxen, ketorolac, diclofenac, or aspirin. This is a very important medication interaction. Steroid plus NSAID equals higher GI concern. Patients should report black tarry stools, vomiting blood, coffee ground emesis, severe stomach pain, or unexplained weakness and dizziness. Taking oral corticosteroids with food may help reduce stomach upset. Providers may also order stomach protection, such as a proton pump inhibitor or H2 blocker, depending on the patient's risk. Pop test question: which combination increases concern for GI bleeding? A. Prednisone plus ibuprofen. B. Prednisone plus water. C. Methylprednisolone plus a meal. D. Prednisone plus a blanket. The correct answer is A. Corticosteroids combined with NSAIDs can increase the risk of GI irritation and bleeding. Now let's talk about fluid retention and blood pressure. Corticosteroids can cause the body to hold onto sodium and water. This can lead to fluid retention, swelling, weight gain, and increased blood pressure. Patients with heart failure, hypertension, or kidney disease need careful monitoring. For example, a patient with heart failure starts prednisone and then develops swelling in the legs, shortness of breath, and sudden weight gain. That should be reported because fluid retention may be worsening heart failure. Nursing monitoring includes blood pressure, daily weights if ordered, edema, lung sounds, intake and output, and symptoms like shortness of breath. Teach patients to report swelling, sudden weight gain, or shortness of breath. Pop test question: a patient taking prednisone reports sudden weight gain, ankle swelling, and shortness of breath. What should the nurse do? A. Report it because it may indicate fluid retention or worsening heart failure. B. Tell the patient this is always harmless. C. Give extra salt. D. Ignore it if pain improved. The correct answer is A. Steroids can cause fluid retention and may worsen heart failure or hypertension. Now let's talk about adrenal suppression and tapering. This is one of the most important corticosteroid concepts. When a patient takes corticosteroids for more than a short time, the body may reduce its own cortisol production. The adrenal glands may become sleepy because the medication is providing steroid effect from outside the body. If the medication is stopped suddenly, the body may not be able to make enough cortisol right away. This can cause adrenal insufficiency or adrenal crisis. Symptoms can include severe weakness, fatigue, nausea, vomiting, abdominal pain, low blood pressure, dizziness, low blood sugar, confusion, and even shock. This is why longer steroid courses often need tapering. A taper means the dose is gradually reduced so the adrenal glands can wake back up. Short courses may not always require a taper, depending on duration and provider judgment. But nursing students should remember, do not stop long-term corticosteroids suddenly. Teach patients to follow the taper exactly. Memory tip: steroids need a slow step down. Pop test question: why should long-term prednisone not be stopped suddenly? A. It can cause adrenal insufficiency. B. It causes instant infection. C. It turns into an opioid. D. It stops working forever. The correct answer is A. Long-term corticosteroid use can suppress the adrenal glands, so sudden stopping may cause adrenal insufficiency. Now let's talk about long-term side effects. Short courses of corticosteroids can still cause side effects like insomnia, mood changes, appetite increase, and high glucose. But long-term corticosteroid use adds more risks. These include osteoporosis, muscle weakness, thin skin, easy bruising, poor wound healing, cataracts, glaucoma, Cushingoid appearance, adrenal suppression, increased infection risk, hyperglycemia, hypertension, and fluid retention. Osteoporosis means weak bones. Corticosteroids can decrease bone formation and increase bone breakdown over time. This increases fracture risk. Patients on long-term steroids may need calcium, vitamin D, weight-bearing exercise, bone density monitoring, and sometimes bone protective medications depending on provider guidance. Thin skin and poor wound healing matter because wounds can open more easily and heal more slowly. Cataracts and glaucoma are eye concerns. Patients on long-term steroids may need eye exams. Cushingoid appearance can include round face, weight gain in the trunk, fat pad at the upper back, thin arms and legs, and skin changes. This is sometimes called moon face or buffalo hump, but use respectful language when teaching patients. Pop test question. Which condition is associated with long-term corticosteroid use? A. Osteoporosis. B. Instant bone strengthening. C. Permanent immunity to infection. D. Faster wound healing in every patient. The correct answer is A. Long-term corticosteroids can weaken bones and increase osteoporosis risk. Now let's discuss major warnings and black box warnings. Prednisone and methylprednisolone do not always have one single boxed warning that students memorize like opioids do, but they have very important warnings. First, infection risk. Corticosteroids suppress the immune system, increase susceptibility to infection, may worsen existing infections, and can mask signs of infection. Second, adrenal suppression. Long-term use can suppress the hypothalamic pituitary adrenal axis, also called the HPA axis. This is why tapering may be needed. Third, hyperglycemia. Corticosteroids can increase blood glucose and may require adjustment of diabetes medications. Fourth, psychiatric effects. Corticosteroids can cause mood changes, insomnia, anxiety, depression, mania, confusion, or hallucinations. Fifth, GI risk. Steroids can increase risk of GI irritation and bleeding, especially with NSAIDs. Sixth, fluid retention and hypertension. Steroids can worsen blood pressure, edema, and heart failure symptoms. Seventh, bone and eye risks with long-term use. These include osteoporosis, cataracts, and glaucoma. Eighth, live vaccines. Patients receiving immunosuppressive doses may need to avoid live vaccines unless their provider says otherwise. The nursing school summary is, steroids are powerful anti-inflammatory medications, but they affect the whole body. Now let's talk about nursing responsibilities before giving prednisone or methylprednisolone. First, verify the order. Check the medication, dose, route, frequency, timing, and indication. Second, assess why the patient is taking it. Asthma, COPD, allergic reaction, autoimmune flare, multiple sclerosis flare, inflammatory bowel disease. The reason affects what you monitor. Third, check allergies. Ask about previous reactions to corticosteroids. Fourth, assess infection risk. Check temperature, white blood cell count if available, wounds, cough, urine symptoms, mental status changes, and current infections. Remember, steroids can mask infection. Fifth, assess blood glucose. This is especially important in patients with diabetes or those receiving high-dose steroids. Sixth, assess blood pressure and fluid status. Look for edema, weight gain, lung sounds, and heart failure history. Seventh, assess GI history. Ask about ulcers, GI bleeding, severe reflux, NSAID use, anticoagulant use, and alcohol use. Eighth, assess mood and mental status. Ask about anxiety, depression, insomnia, or history of severe mood reaction to steroids. Ninth, review medication interactions. Look for NSAIDs, anticoagulants, diabetes medications, diuretics, vaccines, and other immunosuppressants. 10th, assess whether the medication needs tapering. If the patient has been taking steroids long-term, do not let them stop suddenly without provider guidance. Pop test question. Before giving prednisone, which assessment is especially important? A. Blood glucose, infection signs, blood pressure, and GI bleeding risk. B. Hair color. C. Shoe size. D. Favorite movie. The correct answer is A. Corticosteroids affect glucose, immune response, blood pressure, fluid balance, and GI risk. Now let's talk about lab monitoring. The labs depend on the patient and the duration of therapy. For blood glucose, monitor fingerstick glucose or serum glucose, especially in patients with diabetes or those on high-dose steroids. For infection, monitor white blood cell count, but be careful. Steroids can increase white blood cell count by demargination, which means the WBC may rise because of the steroid effect, not necessarily infection. So do not rely on WBC alone. Assess the whole patient. For electrolytes, monitor sodium and potassium if the patient is at risk. Some corticosteroids can contribute to sodium and fluid retention and potassium loss. For kidney function, monitor BUN and creatinine in patients with renal disease or fluid concerns. For GI bleeding, monitor hemoglobin and hematocrit if bleeding is suspected. For long-term therapy, monitor bone health, eye exams, weight, blood pressure, and signs of Cushingoid changes. For adrenal suppression concerns, the provider may order cortisol testing or ACTH stimulation testing in certain situations, but that is provider managed. For patients on anticoagulants, monitor INR or other relevant labs depending on the medication. Pop test question. A patient on high-dose steroids has diabetes. Which monitoring is most important? A. Blood glucose checks. B. Eye color checks. C. Hair length checks. D. Shoe size checks. The correct answer is A. Steroids can significantly increase blood glucose. Now let's talk about administration tips. Prednisone is usually taken by mouth. It is often recommended to take it with food or milk to reduce stomach upset. It is often taken in the morning. Why morning? Because the body naturally produces more cortisol in the morning. Morning dosing may also reduce insomnia. However, always follow the provider's order. Methylprednisolone may be oral or IV. For IV methylprednisolone, follow facility policy for reconstitution, dilution, IV push or infusion rate, and compatibility. Some IV steroid doses are given slowly depending on the dose and product. Always check medication references and facility guidelines. For oral methylprednisolone dose packs, patients must follow the schedule carefully. A Medrol dose pack usually has a specific decreasing dose schedule over several days. Patients should not randomly skip tablets or take them all at once. For both prednisone and methylprednisolone, teach patients not to stop suddenly if they have been taking the medication longer term or if they were given a taper schedule. Pop test question. Why is prednisone often taken with food? A. To reduce stomach irritation. B. To make it an antibiotic. C. To prevent all side effects. D. To make it work only at night. The correct answer is A. Taking oral steroids with food may help reduce stomach upset. Now let's talk about patient teaching. Teach patients why they are taking the corticosteroid. For example, this medication helps reduce inflammation in your lungs. Or, this medication helps calm your autoimmune flare. Teach patients to take the medication exactly as prescribed. If they are given a taper, follow the taper schedule. Do not stop suddenly without provider guidance. Teach patients to take oral steroids with food or milk if allowed. Teach them that insomnia can happen. If ordered once daily, morning dosing may help reduce sleep problems. Teach patients with diabetes to monitor blood glucose closely. They may need temporary changes in diabetes medications. Teach patients to report signs of infection. These include fever, chills, sore throat, cough, painful urination, wound redness, drainage, or feeling unusually weak. Teach patients to avoid close contact with people who have contagious illnesses when possible, especially if they are on higher doses or longer-term therapy. Teach patients not to receive live vaccines without provider approval. Teach patients to report black stools, vomiting blood, severe stomach pain, or unusual bruising. Teach them to report mood changes, depression, severe anxiety, confusion, hallucinations, or thoughts of self-harm. Teach them to report swelling, sudden weight gain, shortness of breath, or high blood pressure symptoms. Teach long-term steroid patients about bone health. They may need calcium, vitamin D, exercise, fall prevention, bone density testing, and provider follow-up. Teach patients to wear medical identification if they are on long-term steroids or have adrenal insufficiency risk, depending on provider recommendation. Pop test question. Which patient statement shows correct teaching? A. I should follow my prednisone taper exactly. B. I can stop prednisone suddenly after taking it for months. C. Steroids never affect blood sugar. D. Steroids prevent all infections. The correct answer is A. Patients should follow the taper schedule exactly and not stop long-term steroids suddenly. Now let's talk about what findings should be reported to the provider. Report signs of infection. This includes fever, chills, sore throat, cough, sputum, painful urination, wound drainage, redness, swelling, confusion, or sudden weakness. Report high blood sugar, especially if severe or symptomatic. Symptoms include excessive thirst, frequent urination, blurry vision, fatigue, nausea, or confusion. Report severe mood changes. This includes mania, severe anxiety, depression, hallucinations, confusion, aggression, or suicidal thoughts. Report signs of GI bleeding. This includes black tarry stools, vomiting blood, coffee ground emesis, severe stomach pain, dizziness, or fainting. Report signs of fluid overload. This includes sudden weight gain, swelling, shortness of breath, crackles in the lungs, or worsening heart failure symptoms. Report severe hypertension. Report vision changes, eye pain, or blurred vision. Report severe muscle weakness. Report signs of adrenal insufficiency, especially after stopping steroids. These include severe fatigue, weakness, nausea, vomiting, abdominal pain, low blood pressure, dizziness, confusion, or fainting. Report allergic reaction. This includes rash, hives, swelling of the face or throat, wheezing, or difficulty breathing. Report if a patient stopped long-term corticosteroids suddenly. Pop test question. A patient recently stopped long-term prednisone and now has severe weakness, dizziness, nausea, and low blood pressure. What should the nurse suspect? A. Possible adrenal insufficiency. B. Normal expected finding only C. Improved adrenal function. D. Mild hunger. The correct answer is A. Sudden stopping after long-term steroid use can cause adrenal insufficiency. Now let's walk through a clinical scenario. You are caring for Ms. Jackson, a 58-year-old patient admitted with a COPD exacerbation. She is receiving IV methylprednisolone and nebulized bronchodilators. She also has type 2 diabetes. Before giving methylprednisolone, you review her blood glucose. It is 248. What should you think? You should recognize that steroids can increase blood glucose. You should follow the provider's glucose monitoring and insulin orders. Notify the provider if glucose is outside ordered parameters and continue monitoring. You should also assess respiratory status, oxygen saturation, lung sounds, work of breathing, and response to therapy. Steroids help reduce lung inflammation, but they may raise blood sugar. That is a classic nursing trade-off. Here is another scenario. Mr. Lee is taking prednisone for an autoimmune flare. He says, "I feel better, so I stopped taking it yesterday. I was supposed to taper, but I did not think it mattered." What should you teach? You should explain that stopping prednisone suddenly can be dangerous if the body has become used to it. The taper schedule helps the adrenal glands adjust. He should contact the provider for instructions. Do not tell him to restart or change doses independently unless you have provider orders. But do teach that tapering matters. Here is another scenario. A patient on prednisone reports black stools and dizziness. What should you think? Possible GI bleeding. Ask about NSAID use, aspirin, anticoagulants, alcohol, stomach pain, and weakness. Check vital signs. Notify the provider. Monitor hemoglobin and hematocrit if ordered. Do not ignore black stools. Now let's compare corticosteroids with other medication classes. NSAIDs, like ibuprofen and naproxen, reduce inflammation by decreasing prostaglandins. Corticosteroids reduce inflammation more broadly by suppressing immune and inflammatory pathways. Antihistamines, like diphenhydramine or loratadine, block histamine effects in allergic reactions. Corticosteroids reduce inflammation but do not work as fast as epinephrine in anaphylaxis. Antibiotics kill or stop bacteria. Corticosteroids do not kill bacteria. This is important. If a patient has a bacterial infection and receives steroids, they may also need antibiotics depending on the diagnosis. Steroids can make infection worse if not used appropriately. So do not think of steroids as anti-infectives. Think of them as anti-inflammatory and immunosuppressive. Now let's review the nursing school must-know points. Prednisone and methylprednisolone are corticosteroids. They reduce inflammation and suppress the immune system. Prednisone is commonly oral. Methylprednisolone can be oral or IV. They are used for conditions like asthma exacerbations, COPD exacerbations, allergic reactions, autoimmune flares, inflammatory bowel disease, arthritis, and multiple sclerosis flares. They can increase blood glucose. They can increase infection risk and mask signs of infection. They can cause mood changes, insomnia, anxiety, depression, mania, confusion, or hallucinations. They can cause GI irritation and increase GI bleeding risk, especially with NSAIDs. They can cause fluid retention, hypertension, swelling, and worsening heart failure. Long-term use can cause adrenal suppression, osteoporosis, thin skin, poor wound healing, cataracts, glaucoma, muscle weakness, and Cushingoid changes. Do not stop long-term corticosteroids suddenly. Follow taper instructions. Monitor blood glucose, blood pressure, weight, edema, infection signs, GI bleeding signs, mood, sleep, and labs based on patient risk. Teach patients to take oral steroids with food. Take them as prescribed. Avoid stopping suddenly. Report infection, report bleeding, report mood changes, and monitor blood sugar if diabetic. Memory tip: steroids calm inflammation, but raise sugar, pressure, infection risk, and mood changes. Now let's finish with 5 true or false review questions. Question 1. True or false? Prednisone and methylprednisolone are corticosteroids that reduce inflammation and suppress immune activity. The correct answer is true. Rationale: these medications are systemic corticosteroids with anti-inflammatory and immunosuppressive effects. Question 2. True or false? Corticosteroids can increase blood glucose. The correct answer is true. Rationale: steroids can raise blood glucose by increasing glucose production and reducing insulin sensitivity. This is especially important in patients with diabetes. Question 3. True or false? Long-term prednisone can always be stopped suddenly once symptoms improve. The correct answer is false. Rationale: long-term corticosteroid use can suppress adrenal gland function. Stopping suddenly can cause adrenal insufficiency, so tapering may be needed. Question 4. True or false? Corticosteroids can increase infection risk and may mask signs of infection. The correct answer is true. Rationale: corticosteroids suppress immune responses, which can make infections more likely, worsen existing infections, and hide typical signs like fever or inflammation. Question 5. True or false? Taking prednisone with NSAIDs like ibuprofen may increase GI bleeding risk. The correct answer is true. Rationale: corticosteroids can irritate the stomach and NSAIDs also increase GI bleeding risk. Together they raise concern for ulcers or bleeding. And that is your beginner-friendly nursing pharmacology review of corticosteroids, prednisone and methylprednisolone. Remember, steroids are powerful medications. They can calm inflammation and help patients breathe better, move better, and recover from inflammatory flares. But they also require careful nursing monitoring. Always think about blood sugar, infection risk, mood changes, sleep, blood pressure, fluid retention, stomach bleeding, bone health, eye changes, and adrenal suppression. As a nurse, your job is to give the medication safely, assess the whole patient, monitor labs and symptoms, teach clearly, and report concerning findings early. Thank you for watching, and I'll see you in the next nursing pharmacology lesson.